see in this picture. It can occur in the temporal or in the nasal region as well. When it is covering the punctum, then it will lead to epiphora and the patient will present with watering and sometimes even blurred vision. So what is the management? The management is divided into primary prevention, the medical management and the surgical management. The primary prevention mainly to avoid the eye rubbing and UV exposure, as these are risk factors, and to treat any underlying ocular surface issues. The medical management is reserved mainly for mild diseases. The mild symptoms, they can be addressed with topical lubrication, blinking exercises, topical antihistamines and topical corticosteroids. However, if it is severe, then surgical management is required. Surgical management primarily involves conjunctival excision. Conjunctival excision, how we are going to do that? A semilunar portion of the conjunctiva, 5 to 6 millimeters posterior to the limbus, is excised. The conjunctiva, it can be closed with absorbable sutures or with glue, and amniotic membrane graft can also be used to cover the conjunctival defect. We can also secure the bulbar conjunctiva to the sclera, as we said that there is loss of adhesion of the conch with the Teno's capsule and the episclera with absorbable sutures. Thermal cautery can also be performed. The fold, it is cauterized, and then the contraction, it leads to resolution of the conjunctival calyces. And forniceal reconstruction is done in order to re-establish the forniceal tear reservoir. Then we move on to the punctal stenosis. What is punctal stenosis? Can anyone tell? Yes. Punctal stenosis is clinically defined as a punctum calibre restricting tear drainage in the absence of canalicular or NLD obstruction. So first we have to rule out that there is no canalicular or NLD obstruction, and then we can label a patient to have punctal stenosis only. And in literature, punctal stenosis has been defined as a punctal diameter of less than 0.3 millimeters, or inability to intubate the punctum with a 26 gauge cannula without dilatation. If you are not dilating the punctum and the inability to pass the probe through it, that can lead to the diagnosis of punctal stenosis. So what are the different causes of punctal stenosis? It may be congenital, as associated with anophthalmos and microphthalmos. It may be idiopathic, age-related changes, and female gender, it is more common in females as compared to the males. It may be inflammatory due to chronic blepharitis, which is one of the most common causes, or dry eye. It can be mechanical due to trauma to the lid or lid eversion, malposition of the lid. It can be iatrogenic by punctal electrocautery or topical anti-glaucoma medications. We know that they are also associated with punctal stenosis. Or it can be infectious, as seen with herpes simplex virus and zoster virus as well. So these are the different causes of punctal stenosis, and we have to rule them out in order to treat the pathology. How are we going to diagnose? The slit lamp examination, it is very important. We have to see the shape and the size of the punctum. We have to see if any membrane is covering it or mechanical obstruction. As with all the cases of epiphora, we have to measure the marginal tear strip. The fluorescent dye disappearance is done, and presence of fluorescent in the fornix after 7 minutes indicates a delay in the dye appearance. Then after doing all the tests for epiphora, as we discussed previously, we proceed towards the probing and irrigation of the lacrimal system. So lacrimal probing with irrigation helps to differentiate punctal stenosis from canalicular or nasolacrimal duct obstruction. As discussed previously, we are only going to label it when we have ruled out that there is no canalicular or NLD obstruction. In punctal stenosis, there is difficulty passing the probe past the punctum, and without dilatation, it will be also difficult to pass the probe through it. What are the different types? We divide it into primary punctal stenosis and the secondary punctal stenosis. If there is no eversion, punctal eversion, then we label it as primary punctal stenosis, and with punctal eversion is secondary punctal stenosis. The management from primary punctal stenosis is simply dilatation, and punctoplasty can also be performed, which is the 1 snip, 2 snip or 3 snip procedure. And because in secondary punctal stenosis there is punctal eversion, so we have to correct the eversion as well with the retropunctal Ziegler cautery technique, medial conjunctivoplasty or lower lid tightening, as we discussed all these in the management of acromion as well. So moving to the punctoplasty, we have the 1 snip, 2 snip and 3 snip procedures. Basically, we are dilating the punctum by excising the posterior ampular wall of the punctum. So this is the 1 snip procedure. You can see a single snip is given in the posterior wall and it will lead to the dilatation of the punctum. This is the 2 snip procedure in which a vertical cut is given to the medial and the lateral wall and then removal of the intervening tissue by a short horizontal third cut is given. In the 3 snip procedure, first a vertical cut is given down the ampulla and then a horizontal cut is given along the roof and a flap is created and then the base of the flap is removed diagonally, and all of these are basically relieving the punctal stenosis and causing increased diameter of the punctum. Moving to the canalicular obstruction. The frequency of canalicular obstruction has been reported to be between 16 and 25% of all patients presenting with obstructive epiphora. So basically, how are we going to classify? As discussed in the first slide, the anatomy of the canaliculus is very important because based on that, we are going to determine where the level of the obstruction is. So it can be proximal obstruction, it can be mid-canalicular and distal obstruction. A proximal obstruction, as seen in the figure A, involves the initial 2 to 3 millimeter from the punctal opening. So basically along the vertical contour of the punctum. And the mid-canalicular is 3 to 8 millimeters from the punctum, as seen in picture B, and distal from a membrane at the opening of the common canaliculus on the lacrimal side. So this is how we are going to classify the canalicular obstruction. Diagnosis, again, we are going to do starting with all the tests for epiphora. The detailed slit lamp examination is done, marginal trace tip measurement, dye disappearance is done, and then we move on to the next step, which is probing and irrigation. So with probing, the length of the canalicular patency distal to the punctum can be measured. So as you can see in the video as well, the probing is being done. If a hard stop is filled, then what does this indicate? That there is patent canalicular system, because the hard stop is going to be due to the lacrimal bone. So the canalicular system is patent. If there is soft resistance which cannot be overcome with the movement of the probe, it signifies obstruction of the canaliculus. Gritty sensation or mild resistance while passing the probe will imply canalicular stenosis. So the location of the canalicular stenosis and obstruction is measured by grasping the punctal end of the probe and withdrawing it from the canaliculus. Whenever we feel the resistance, we are going to grasp it from the punctal end and take out the probe, and then we are going to measure that, and from that we are going to know that what was the level of the obstruction and classify it proximal, mid or distal. Moving to the irrigation of the lacrimal system, it will also provide us valuable information if the return is from the same punctum. With some passage of fluid to the nose, it can imply canalicular stenosis. There is regurg from the same punctum and the patient says that he feels it in the throat as well. It will imply canalicular stenosis. In common canalicular obstruction, there is return of clear fluid from the opposite punctum. So this will indicate common canalicular obstruction. And the return of the fluid along with some mucus through the opposite punctum will signify nasolacrimal duct obstruction. Because the fluid will be coming from the sac and from the opposite punctum, it will be fluid along with mucus. That will be NLD obstruction. Patient with stenotic NLD feel the passage of fluid to the nose with minimal reflux from the opposite canaliculus. In common canaliculus, there will be high velocity flow from the opposite punctum. As you can see in this picture, on irrigation, there is high velocity flow from the opposite punctum. This indicates common canalicular obstruction. Again, this is a diagram showing us the different scenario. The, picture A, it indicates complete canalicular obstruction, and there is regurg from the same punctum. And in picture B, there is common canalicular obstruction, and the regurg is from the opposite punctum. In picture C, there is complete nasolacrimal duct obstruction, and there is regurg from the opposite punctum, which involves fluid as well as the mucus. And in picture D, there is partial NLD obstruction. There is regurg from the opposite punctum, but the patient will have some feel the fluid in the throat as well. And in picture E, there is patent lacrimal drainage system, and as you can see that all of the fluid is passing downwards towards the nose. Then moving to the partial obstruction, the management of canalicular obstruction. If there is partial obstruction, it is treated simply by intubation or placement of a silicone stent for 6 weeks to 6 months. You can see this is mini monocam monocanalicular stent. This is the silicone tube, and this is the bulbous end, and this is the circular collar end. Here again you can see that the tube is stent. It is being placed inside the canaliculus. The stent has been advanced, and there is insertion of the collarette into the punctum. Now, when we have complete obstruction, then again we have to see whether it is proximal or distal. For proximal or mid-canalicular obstructions, reconstruction is required. This canalicular obstruction, the focal part, it is excised, and the cut ends of the canaliculus, they are anastomosed over a stent. So this is for partial or mid-canalicular obstruction. But if there is distal obstruction, we have to refine the scarred segment to establish a patent lumen. And once the lumen it has been established, we place a stent in order to prevent contracture. A stent is placed, and balloon canaliculoplasty can also be performed following lacrimal trephination. So this is for distal obstruction. And when there is obstruction of the common canaliculus, complete obstruction, then we have two options. Either we can proceed to canalicular DCR, or we can proceed to conjunctival DCR. So canaliculo-dacrocystorhinostopy, when there is total obstruction to the common canaliculus. The common canaliculus is removed, and the canalicular system is directly anastomosed to the lacrimal sac. And if we are using silicone stent, it may increase the success rate of this surgery. And in conjunctival DCR, again we are doing when the canalicula, they are severely obstructed, and a Pyrex glass tube is placed connecting the caruncle through the osteotomy site into the middle meatus. So this was all about the canalicular obstruction. Moving to the next acquired disorder, which is dacrolithiasis. It is more common in males as compared to the females. The pathophysiology is unclear, but it is thought that tear stagnation, which is occurring secondary to the obstruction of the lacrimal drainage system, may precipitate stone formation, which tends to be associated with squamous metaplasia of the lacrimal sac epithelium. We know that the normal epithelium of the lacrimal sac is columnar epithelium, stratified columnar epithelium with goblet cells. So the squamous metaplasia is occurring, which tends to precipitate stone formation. The patient presents with intermittent epiphora, recurrent attacks of acute dacrocystitis, and lacrimal sac distension. On examination, the lacrimal sac will be distended and relatively firm, but it is not inflamed. This is important. Because in acute dacrocystitis, the lacrimal sac will be inflamed and tender. It's not in this case. Mucus reflux on pressure may or may not be present. The treatment for dacrolithiasis is dacrocystorhinostopy. Chronic canaliculitis is an uncommon condition which is frequently caused by actinomyces, which is an anaerobic gram-positive bacteria. The patient presents with unilateral epiphora, which is associated with chronic mucopurulent conjunctivitis, which is refractory to conventional treatment. There is pericanalicular redness and edema, as you can see in the picture as well, and mucopurulent discharge on pressure over the canalicular disc. A pouted punctum may be a diagnostic loop in mild cases. So this picture, it shows the superior and inferior pouting puncta. There is no lacrimal sac involvements. Concretions, which are sulfur granules, they are produced as a result of metabolic products of the actinomyces, and they are expressed on canalicular compression following canaliculotomy. What is the treatment? The treatment is canaliculotomy plus curettage of the concretions with topical antibiotics. If we are simply given topical antibiotics, it will have no role unless we are combining it with canaliculotomy and curettage of the concretions. Dacrocystitis, it is the inflammation of the lacrimal sac, which typically occurs secondary to obstruction of the nasolacrimal duct. The etiology most commonly is staphylococcal and streptococcal. However, other organisms such as Haemophilus or Pseudomonas or Pneumococcus involvement can also be present. Acute dacrocystitis, the patient presents with subacute onset of pain in the medial canthal area, which is associated with epiphora. On examination, a very tender, tense, red swelling develops on the medial canthus, which commonly progresses to abscess formation, and there may be associated preseptal cellulitis as well. The initial treatment involves the application of warm compresses, and the patient is prescribed systemic antibiotics. Irrigation and probing should not be performed in acute dacrocystitis, and incision and drainage may be considered if the pus points as seen in this picture and an abscess is about to drain spontaneously. However, this carries a risk of formation of the sac and skin fistula. Dacrocystorhinostomy is commonly required after the acute episode settles, and it reduces the risk of recurrent infection and can result in the closure of the fistula. This is in this picture, healing fistula can be seen after acute dacrocystis. Chronic dacrocystis, the presentation is with chronic epiphora. However, there will be a painless swelling at the medial canthus. If an obvious swelling is absent, pressure over the sac can still result in mucopurulent canalicular reflux, and treatment for chronic dacrocystis is dacrocystorhinostomy. So the nasolacrimal duct obstruction and the DCR will be discussed in the next lecture. We'll have a quick review of the causes and the treatments for epiphora, the obstructive causes which we have discussed today. When there's punctal obstruction, what will be the treatment? Dilatation and punctoplasty, 1, 2, 3 snip, whatever is the preference. When there is canalicular obstruction, first of all, what we have to see? What is the location of the obstruction, and depending on the location, that will we'll have our treatment plan. If there is simply partial obstruction, what are we going to do? Silicone intubation. We said intubation for 6 weeks to 6 months. If there is complete canalicular occlusion, reconstruction. And in common canalicular obstruction, what will be the treatment? CDCR or yes. And in canaliculitis, what did we say? What is the treatment for canaliculitis? Canaliculitis. We said that topical antibiotics will have limited role unless they are combined with canaliculotomy and curettage of the concretions. And in nasolacrimal duct obstruction, we are going to proceed towards the DCR, which will be discussed in the next lecture. So a 60-year-old woman presented with a 3-month history of intermittent tearing and macturing in her right medial canthus. Additionally, she has noted a focal swelling and tenderness near her lid margins. Which of the following suggests a diagnosis of canaliculitis? A palpable subcutaneous mass over medial canthal area, gritty sensation of probing with yellow tinged concretions, mucopurulent reflux from punctum with compression on the sac, non-tender firm masses on palpation of the lacrimal sac, reflux of fluid with mucus from the opposite punctum. Yes, gritty sensation of probing with yellow tint secretions. A 40-year-old male with epiphora and obstruction in the sac duct junction would be expected to have negative dye disappearance test, negative Jones 3 test, negative dye disappearance test plus positive Jones 2, negative dye disappearance plus positive Jones 3, positive dye disappearance test plus negative Jones 1, positive dye disappearance test plus positive Jones 1. Positive dye disappearance test, that will be delayed, and negative Jones 1 test because the obstruction is at the level of sac and duct. So no fluorescence will be recovered from the nose. A 60-year-old male presented with acute lancinating pain in the medial canthal region with minimal non-inflamed enlargement of lacrimal sac is most subjective of actinomyces canaliculitis, acute dacrocystitis, chronic dacrocystitis, impacted dacrolith, Wegener's granulomatosis of lacrimal sac. calcination, impacted decrolith. That is the cause. Thank you.
Well done, good presentation, very extensive और बहुत अच्छा cover किया है subject को. You see, the common mistake when we do a probing sac singeing is kinking the canaliculus. So to prevent kinking of the canaliculus, we always stretch the outer part of the lower lid, in an outer direction and downward direction, like this, if we are probing the inferior canaliculus. Because kinking of the inferior canaliculus, for example, will give a false impression of canalicular obstruction. जब canalicular obstruction हमें मिलती है तो हम वहीं पे छोड़ देते हैं, बट इसका कोई ख़ास फ़ायदा कोई नहीं है कुछ करने का. The punctal stenosis we can relieve with punctoplasty, results are good. But canalicular obstruction is a difficult subject. You see, canaliculi are lined on the inner side by stratified epithelium. If you sort of distend or if you make a passage with force, there will be scarring. So unless and until the passage is lined by a stratified epithelium, it will not open. The scarring will lead to obstruction. So अगर आप जोर लगा के कैनालिकुलस में से प्रोब पास कर भी दें तो उसका फ़ायदा कोई नहीं, वो हफ्ते दो हफ्ते बाद फिर बंद हो जाए. So probing sac syringing is not therapeutic in adults. Probing sac syringing बच्चों में तो क्यूरेटिव होती है, इसलिए कि वैल्व ऑफ फेस्नर है आखिर में एनएलडी के, तो वो परफोरेट नहीं हुआ, आपने परफोरेट कर दिया. लेकिन ये एक बड़ी कॉमन मिस्टेक है, मैं देखा कि वो प्रोबिंग करवा लें, सिरिंजिंग करा लें, उससे बेहतर. एडल्ट्स में प्रोबिंग सैक सिरिंजिंग इज ओनली डायग्नोस्टिक, नॉट थेराप्यूटिक. हमने देखना है कि इसका करना क्या है. वो मैंने पहले भी कहा है कि प्लग जो है जब भी हम करते हैं पंक्टल 1 स्टेप और 2 स्टेप, तो साथ प्रोबिंग सिरिंजिंग ज़रूर करते हैं. सिर्फ पंक्टम खोलने का कोई फ़ायदा नहीं अगर आगे कैनालिकुलस बंद है या एनएलडी ऑब्स्ट्रक्शन है. इसी तरह अगर डीसीआर कर दें और कॉज हो पंक्टल स्टीनोसिस तो फ़ायदा कोई नहीं है डीसीआर करने. सो जब पेशेंट हमारे पास आता है वाटरिंग की कंप्लेंट कर रहा है, वाटरिंग में जो ऑब्स्ट्रक्टिव एलिमेंट की वजह से हो उसको कहते हैं एपीफोरा. तो वाटरिंग और एपीफोरा में क्या डिफरेंस है? द वाटरिंग ड्यू टू ऑब्स्ट्रक्टिव रीजन इज कॉल्ड एपीफोरा. अगर हाइपरसिक्रीशन की वजह से है, कंजक्टिवाइटिस की वजह से है, कोई फॉरेन बॉडी चली गई है, तो फिर उसको एपीफोरा नहीं कहते. सो पहली चीज़ जो हम देखते हैं एपीफोरा के पेशेंट्स में, वो देखते हैं कि लिड की पोजीशन ठीक है, जिस तरह उन्होंने कहा एक्टोपियन है, तो आगे जाने का फ़ायदा कोई नहीं. पहले एक्टोपियन एड्रेस करें. जो आप प्रॉब्लम जो आपको नज़र आ रही है तो पहले उसको ठीक करना होगा. लिड लोअर लिड लैक्सिटी है तो आप प्रोबिंग सैक सिरिंजिंग करने का कोई मकसद नहीं है. पहले आप लिड लैक्सिटी ठीक करें. लिड अपनी जगह पे ठीक हो गई, फेशियल पाल्सी है, लिड बाहर आई हुई है, अब क्या फ़ायदा होगा. तो पहले उसको करेक्ट करें. उसके बाद फिर आपने पंक्टम देखा, उसकी पोजीशन देखी. नॉर्मली द पंक्टम शुड नॉट बी विजिबल. अगर पंक्टम विजिबल है इसका मतलब है पंक्टल इवर्शन है. तो वो हम क्या ऑपरेशन करते हैं उसके लिए, पंक्टम को वापस अपनी जगह लाने के लिए मीडियल कंजक्टाइवोप्लास्टी, डायमंड शेप्ड एरिया यहाँ पे कंजक्टाइवा का हम एक्सरसाइज करते हैं बिलो द पंक्टम इनर साइड, और जब हम स्टिच करते हैं तो पंक्टम ऐसे अंदर की तरफ चले जाते हैं. सो ये कंजक्टाइवा का. अब हमने पंक्टम की पोजीशन देख ली, फिर हम देखेंगे उसका डायमीटर कितना है, उसका साइज़ कितना है, फिर प्रोबिंग करेंगे और सैक सिरिंजिंग करेंगे. और इसमें एक दो रेयर लेकिन एडल्ट्स में जब 50 प्लस हमेशा आप ज़हन में रखें कि कोई ट्यूमर हो सकता है. जो ऑब्स्ट्रक्ट कर रहा है. सो प्रोबिंग स्क्रीनिंग करते हैं और ब्लडी डिस्चार्ज आता है सीरो सेंगुइनस किस्म का, तो आप सस्पेक्ट करें कि कोई ट्यूमर है. तो ये भी एक चीज़ ध्यान में रखनी चाहिए 60 प्लस एज के जो लोग हैं. कंजक्टाइवो टेक्नोसिस्टोराइनोस्टमी के कोई बहुत अच्छे रिजल्ट्स नहीं. हम क्रैंकल एक्सरसाइज करते हैं और लिस्टर जॉन ट्यूब डाल देते हैं. पहली बात तो ये होती है, उसका एक कॉलर होता है, उस पर आप सूचर भी लगा सकते हैं, लेकिन वो डिसलॉज हो जाती है या बाहर निकल आती है या नीचे चली जाती है, उसको वहाँ पे टिकाना मुश्किल. तो वो यहाँ पे हमने किए हैं. तो आमतौर पे यही होता है कि 2-3 दफ़ा पेशेंट आता है और 2-3 दफ़ा के बाद पता चलता है वो कोई पता नहीं चलता किधर है. फिर लिस्टर जॉन ट्यूब का जो इंफीरियर एंड है वो टर्बिनेट के साथ लग सकता है, वहाँ पे ऑब्स्ट्रक्शन हो सकती है. उसके ट्यूब के अंदर जो है वो म्यूकस आ जाता है, प्लग बन जाते हैं, वो भी ऑब्स्ट्रक्शन हो सकता है. सो मैंने किए हैं कंजक्टाइवो टेक्नोसिस्टोराइनोस्टमी, लेकिन वो जो लिस्टर जॉन ट्यूब्स, लेकिन कुछ सेटिस्फैक्ट्री रिजल्ट, इसलिए हम पेशेंट को कह देते हैं कि फ़ायदा होने का इम्कान है. तो अभी एक नई लिस्टर जॉन ट्यूब आई है, वो सेल्फ रिटेनिंग टाइप है. उसका इस तरह का है कि ऊपर भी थोड़ा सा कैलिबर बड़ा है, नीचे भी कैलिबर, तो दरमियान में नेक सी आ जाती है. वो नेक जो है वो अटका देते हैं इस पे, लेकिन वो हमारे पास अभी पहुंची. सो वो सेल्फ रिटेनिंग टाइप उसको लिस्टर जॉन ट्यूब कहते हैं. सो दिस वाज ऑल अबाउट एक्वायर्ड ऑब्स्ट्रक्शंस. तो एनी क्वेश्चन?
सर ने कहा कि प्रोबिंग स्टिचिंग करते हुए अगर ब्लड ब्लीड हो जाए तो ट्यूमर हो सकता है. प्रोबिंग कि आपने जो प्रोब अंदर लेके जानी है उसका साइज अप्रोप्रिएट रखें, बहुत ज़्यादा बारीक प्रोब नहीं लेके जानी. अब 26 गेज प्रोब के अंदर जाएंगे, कहीं ना कहीं वो किसी गलत डायरेक्शन में जाएंगे, फिर ब्लीड ही होना, और उसके बाद फिर रिकरेंट इन्फेक्शन ही खत्म नहीं होता.
इसीलिए हम एक्यूट डेक्लोसिस्टाइटिस में नहीं करते हैं प्रोबिंग. तो सारा जो फ्लूइड होता है सराउंडिंग एडिमेटस टिश्यू होते हैं, तो आप आराम से वो उसमें फॉल्स पैसेज बना सकते हैं, पता नहीं चलता. तो प्रोबिंग स्टिचिंग में सारी फील ही है. सो अगर आपको आराम से कैनालिकुलस के अंदर प्रोब जा रहा है तो आप कंफर्टेबल हैं कि जी कैनालिकुलस पेटेंट है. लेकिन जहाँ पे आपको थोड़ा सा रेजिस्टेंस मिलती है आप रुक जाते हैं, उनको जोर लगाने की कोशिश नहीं करते. इसी तरह सिरिंजिंग में भी जो एक कॉमन मिस्टेक होती है ना कि पूरा जोर लगा के सिरिंज खाली कर दी, वो जी पास हो गया. भाई जो टीयर्स ने इतने ज़ोर के साथ तो नहीं जाना ना एनआरडी में. तो अगर आराम से नहीं जा रहा फ्लूइड तो इसका मतलब है पार्शियल ऑब्स्ट्रक्शन. तो सिरिंज पे जोर लगाने की ज़रूरत नहीं. अगर सिरिंज में आराम से फ्लूइड जा रहा है तो उसका मतलब है पैसेज नॉर्मल है. अगर जोर लगाने पे जा रहा है तो उसका मतलब है पार्शियल ऑब्स्ट्रक्शन है.
नहीं, वो बहुत मोमना ने जो स्टैंडर्ड आज बड़ी अच्छी मुझे प्रेजेंटेशन बहुत अच्छी लगी. द स्टैंडर्ड बाकी सबके लिए भी एक तरह से.
और इसमें जो आप देखें एमसीक्यूज भी उन्होंने कल मुझे कंफर्म कराए थे कि जिसमें मसला तो नहीं है. तो वो मैं
करना साहब बहुत अच्छा.
देखें हम जब किसी परफॉर्मेंस को कहते हैं ना अच्छा या बुरा, तो हमें इसको फीडबैक. तो फीडबैक में जो हम मेडिकल एजुकेशन में पढ़ते हैं कि आपको चाहिए कि पॉइंट्स दें कि जी ये ठीक था, ये ठीक था, ये खाली ये कहना हाँ जी ठीक था, वो उसको फ़ायदा नहीं होता. अब एमसीक्यू में जो चीज़ें ठीक थी वो एक नंबर 1 5 ऑप्शन थी. नंबर 2 जो ऑप्शंस थी वो अल्फ़ाबेटिकल ऑर्डर में थी. नंबर 3 जो स्टेम था वो सिनारियो बेस्ड कि जी पेशेंट को ये किया तो ये हुआ, बजाय कि रिकॉल करने. रिकॉल क्या होता है C1, और सिनारियो विद प्रॉब्लम सॉल्विंग क्या होता है C2 C3. सो ये सारे प्लस पॉइंट आपको पता होंगे तो आप इनको अप्रिशिएट भी कर सकेंगे और इसको फॉलो भी कर सकेंगे. तो वेल डन.